met in many cases for almost 2 years, although some of my patients follow me frequently. So yes, it's a big topic. We're talking about overview in clinical management for Parkinson's disease. But if you talk about detail, probably we need a whole night. However, we try to be brief, okay? And again, when people talk about Parkinson's disease, we always brought the James Parkinson description, so-called shaken palsy. This is always back in 1817 when he described the whole, mostly motor symptom-wise. However, if you're talking Parkinson's disease, yes, frequently we have patients a resting tremor, the bradykinesia, rigidity, and gait and balance changes there. And it is a progressive neurodegenerative condition due to the loss of the dopamine neurons in the brain. However, and Parkinson's disease is not only just the motor symptoms. There's many of the non-motor symptoms now actually we find out maybe as important. Some of them are earlier before the motor symptoms started. Many of the others might be more important and more disabling in the advanced Parkinson stage. And the non-motor symptoms, including the autonomic dysfunction, particularly and bladder issue, sexual dysfunction, and orthostatic hypotension, and depression, anxiety, cognition issues, sleeping disorder, fatigue, and etc. A number of non-motor symptoms as well. It's a very common condition, and yes, age probably is the most common risk factor. As we notice that in general population probably is about 0.1 to 0.2%. However, and patient, people after 65-year-old, the risk is about 10-fold. That estimate about close to 1 million Parkinson patients in United States. So the annual incident roughly about 20 new patients per 100,000 population. So the size of Jacksonville, and we have probably about 1 million population here. And that means we have probably 200 new Parkinson patients a year in Jacksonville area. Just give it an example there. So as you can see from the bottom panel, age is the major risk factor there.
Dr. Huang?
Yeah.
Can you share your screen?
Yep. Oh, my screen's not shared. I'm sorry.
It's okay.
Okay, let me see. We haven't. I'm sorry.
It's okay.
So now we are shared.
Yeah, we're sharing, and I think you're going to put it on the full screen. Yep.
Okay. There you go. So again, it's more common in elderly population, as you can tell from this figure, and the 60s, 70s, 80s are more prevalent. Okay, although there's some young onset before 60-year-old, but overall, that's a very small percentage of the patient. And this is the just a kind of a overview what the burden of Parkinson's disease might be. And yes, they reduce the quality of life and the functional impairment actually affecting patients' employment stage. And of course, and other high risk of the depression, cognition issue as well, and increasing medical expense and caregivers burden as well. Okay. I don't know, I mean, many of you may interest about what the brain look like in Parkinson, but the simple way to illustrate is the upper panel basically is normal of the brainstem midbrain area. A highlight area here, that's where the dopamine neuron that located is substantial nigra area, is the dark of the location here. And as compared to the lower panel of the Parkinson patient, the dark area and where the dopamine neuron located, has been degenerated, and you see the dark color replaced by kind of a light yellowish. So the patient lost substantial of dopamine neurons in the lower panel. Okay. When we clinically seen the patient have classic Parkinson symptom, the tremor, bradykinesia, rigidity, and that is the classic so-called motor symptoms, and patients started having loss of the dopamine neurons in brainstem area already. However, many of the study now suggest Parkinson patients' symptom probably started many years ago, and some study always and back in so-called pre-drone up to 20 years ago. And many of the non-motor symptoms, like for example, constipation and REM sleep disorder, lost sense of smell, depression, and those could happen and more than 20 years before patients started motor symptoms. And there are some pathological findings. For example, the sensory nerve was affected, or the patient's sleeping related the neuron in the brainstem might be degenerate before the substantial area was affected. Yes, as symptom progressing, particular patients started having cognition issue already, then the degeneration has spread in not only just the brainstem, but it eventually affecting the entire brain. That was the natural progression we can see at the Parkinson's disease. However, I have to point out, as always said when I talk to the patient, and even Parkinson's disease, it is a progressive condition. We're looking for a slow progressive condition. It's not like a 1 week, 1 day, or even 1 year sudden change. If a patient has sudden change, there's always something else going on. The neuronal degeneration process takes many years to change and slow progressing if the typical Parkinson's disease. Okay. And clinically, and we always using the staging wise, that's the so-called typical Holmes and Yard stage. And usually we have 5 stages. There are limitations about staging wise. However, it's very useful when we're using that stage and you have a general sense of what the patient's overall the Parkinson symptom look like. And if it's the early stage, usually probably stage 1, that's one side of the symptom. The moderate stage is stage 2, both sides involved and either without balance issue, that's stage 2, or both sides involved, they have balance issue. However, patients are able to ambulate independently without any walking assistant, like a walker or cane. That's stage 3. Stage 4, as those patients still able to ambulating, but they started losing more balance. They need a walker or cane for ambulating. But stage 5 are those patients and probably not able to ambulate much anymore and either chair bound and bed bound. Now, the staging wise is useful clinically. However, it is a limit in the way we have to realize. Number one is that stage is a solid based on the motor symptoms, okay? Number 2 is that sometimes the stage can be misleading. For example, when patients taking medication and medication working well, they don't have balance issue, and there might be a stage 2. When the patient's on the off stage and the medication is not working, they have severe balance issue, they might need a walking device for ambulation, might be stage 4. So that can be changeable and depends on the state of the circumstance there. But the stage is a slow change anyway. And we've seen that Parkinson patient progress from mild to severe stage in which patient cannot taking care of themselves can be 5, 10, 15 years. Everybody's different. In average, Parkinson patient we've seen nowadays and survive with Parkinson's disease probably about 17.5 years. And mostly devastating outcome with advanced Parkinson patient are because either the aspirate was infection or urinary tract infection, or if they fell and caused some fracture and traumatic injury, that's what the issue, okay? So we're going to focus a little bit more of the management and clinical management of Parkinson's disease. And we know we don't have a cure for Parkinson's disease yet, and we don't have anything to slow down or halt a progression yet, although there are some of the therapy or exercise might help somewhat and slow down the progression. But the current ultimate goal is to provide adequate symptomatic relief and minimize the disability, and try to delay or reduce the complications. And hopefully we can adequately improve the symptom patient have reasonable function level in terms of early on, maybe even employment, as symptom progressing, and they can still maintain reasonable quality of life. And in their way, and in early on, we asked me why choosing movement disorder, and this is one of the area probably I'm very interested in, because we have so many treatment available and for movement disorder, and this is only one of these slides showing that how many medication or therapy we have currently for Parkinson's disease, just medication itself. And maybe it's a business slides and it can be confusing there, but simply I can summarize with probably 4-5 groups, okay? One group is basically focused on the dopamine therapy. That's on the left-hand panel. Okay, the first group is levodopa. They can have immediate release form, control release form, sublingual form, or even intestinal and the gel form, Duopa, or inhaler form for rescue in pre-jet. All those are eventually the active ingredients like levodopa. And levodopa eventually converted into dopamine, try to replace the dopamine level. And that's where exactly the main ingredient, when patient lost a dopamine neuron, they're not able to produce enough dopamine. Okay, that's the levodopa. Second class medications are calm inhibitor, and that including tocopone and entacapone, Ongentys, the new class now. And calm inhibitor basically reduce the levodopa being metabolized peripherally, particularly GI. Some cases, tocopone may also enhance the dopamine or reduce dopamine being metabolized in the brain as well. So the calm inhibitor itself doesn't have value, but when they're used together with the levodopa, it will reduce levodopa being metabolized from GI, and they will enhance the levodopa concentration, potentiate the levodopa effects. MMO inhibitor, and again, MMOB inhibitor, the selective group, and 3 major medications available now, selegiline, resegiline, and Zhiago. Those medication is reducing dopamine being metabolized in the brain, and that will allow the dopamine work more efficiently. So those all working into the dopamine on the left side panel. On the right side, there's 4 groups. One is the dopamine agonist, which is acting directly like a dopamine, directly stimulate dopamine receptors. And second group is the anticholinergic, which is not common use anymore. And this class is very old medication. They help the tremor part, but not much any other symptoms. And NMDA receptor antagonists, including amantadine or the control and immediate release group. And they help some of the Parkinson's symptoms modestly, but it also improve the dyskinesia. And this is a new class, adenosine antagonists and neurons. this class of medication and is used as adjunct therapy to make it the carbidopa levodopa last longer. Okay, so levodopa, it is still the most effective medication in terms of helping the cardinal signs and symptoms in Parkinson, tremor, such as tremor, bradykinesia, rigidity, and gait imbalance. However, levodopa, if taken alone, rapid metabolize in your GI. That's why we need a combination with the carbidopa to block that peripheral metabolism, make it more levodopa absorb, get to the bloodstream. And levodopa require amino acid transporter and for absorption and across blood-brain barrier. That sometimes can be a problem with protein intake, and the protein intake competing for the absorption, it will reduce the levodopa efficacy. Okay. Regardless, however, since the levodopa approved, and look at the treatment-wise, and the rate of clinical progression has been significantly slow, and patients' life expectancy is substantially increased if you look in the way compared to untreated patient versus a treated patient with levodopa. So untreated patient, look at the percentage of patient, the stage progression, the stage 5 and 4 to 5, that's a more advanced stage, and over 15 years follow-up. And as compared to patients treated with levodopa, I mean, the quality of life significantly improved, and the disability has been significantly reduced over 15-year follow-up. So there are times people argue, hey, there's no cure for Parkinson's disease. Why you need to start treatment? So treatments not only improve the motor symptom-wise, but many patients have much better quality of life, and we might able to actually reduce the disability and substantially improve life expectancy for Parkinson's patients. And of course, and like any medication, it's not like a medication just have the good part and they don't have limitation. So levodopa and long-term therapy can have dyskinesia, and itself, yes, can have confusion, hallucination as well, but it's not levodopa itself. But this combination of the Parkinson progression and the cognition issue in Parkinson with the high dose levodopa. Okay, yes, levodopa has a wearing off issue because of short half-life, and also the absorption issue in advanced Parkinson patients. So patients are gonna have wearing off, meaning the levodopa dose eventually don't work as effective. Inhibitor, as I said, basically reduce levodopa being metabolized from the GI system or from the liver. That will make it the levodopa work more efficient and try to reduce the off time and increase in the on time better. And however, because the CAM inhibitor in potential increase levodopa absorb, and then one of the potential adverse effect is increase in dyskinesia. Dopamine agonist, as I said, is directly stimulate the dopamine receptor, so it will not be interfering with the absorption and food issue, and they will be effective in terms of treating many of the Parkinson motor symptoms, tremor, bradykinesia, rigidity as a monotherapy, but it can be also used in combination with levodopa to help reduce the wearing off and increasing the on time in advanced Parkinson population who is taking levodopa alone. And because we are able to reduce levodopa intake, the dopamine agonist might reduce the risk of levodopa-induced dyskinesia. However, again, like any other medication, the dopamine agonist might have their own share of a potential side effect, like the GI side effect, nausea, vomiting, and drowsiness, the blood pressure drop with dizziness and peripheral edema, hallucination, and particularly and more prevalent is the impulse control disorder, such as impulse gambling, excessive spending, or hypersexual in some patients. MMO inhibitor basically is reduced dopamine being metabolized, which, yes, in combination with levodopa can increase on time and reduce off time. In some study, and suggest this class of medication, particularly started early on, might protect and it might provide some neuroprotection and might slow down the progression of Parkinson's disease. The common adverse effect in this class of medication, including nausea, insomnia, and also static hypertension and hallucination. And the old class, particularly selegiline, the first generation MMOB inhibitor, might have interaction with many of the antidepressants. Anticholinergic medication, as I said, is a very old class medication for Parkinson, even before levodopa, and such as the R10 benztropine. It is very effective for tremor symptoms, but not much for other symptoms. And however, this class of medication, major side effects is dry mouth, dry eyes, constipation, confusion, hallucination, and urinary retention, particularly more in advanced age or elderly population. That make it very, very less likely we use in this class of medication. And particularly, we have so many options available. And I do use it for some tremor predominant patients if their tremor is not responding well to other medications. Now, amantadine is kind of an interesting or unique medication. This is an antiviral agent. It was used for influenza prevention. However, and early on, when some of patients started taking amantadine, and it was observed that their Parkinsonian symptoms improved. That's where amantadine had eventually applied or used for Parkinson's symptoms. And it does help many of the motor symptoms, such as tremor, bradykinesia, rigidity, that in that way, if a combination with the levodopa, it will reduce off time and increase on time. And however, this class of medication also help reduce the dyskinesia. And why the amantadine and help and working for Parkinson patients, and the mechanism may not be entirely clear. And this class of medication kind of interesting. Maybe it's kind of mixture of mechanism. Yes, it does have the NMDA antagonist benefit. That might be the dyskinesia property, but amantadine might enhance dopamine release, and amantadine might work as a dopamine agonist, and amantadine might also and partially work as an anticholinergic. So it's a mixed benefit from amantadine and help Parkinson symptoms. But amantadine might have their own share of the side effect, such as some most common relate to the anticholinergic property, the dry mouth, dry eyes, constipation, and confusion, hallucination, and as well as the leg edema. Okay, this is a new class of medications, the A2A antagonist. It's not recommended use alone for Parkinson's symptoms, but it has been approved for patients who's taken levodopa, but levodopa alone are not sufficient to improve Parkinson's symptoms with more off. So neurons might add the benefit, they increase the on time, reduce the off time with those patients who's taken levodopa alone. The common side effects is increasing dyskinesia and some somnolence. So always, I mean, we have particular students and research and interest. Hey, and if Parkinson is a progressive condition, when you try many different medications already, and if the medication to a certain point not quite effective, or everyday medication has significant side effect patient cannot tolerate, was that, hey, when is a point we're gonna consider the surgical or intervention, surgical treatment for Parkinson patient. Now, it's not every patient have Parkinson disease. We're gonna immediately do the surgery, okay? However, and there are some of the cases, for example, the medication is not sufficient to help the symptom anymore, which patient have significant wear off, and patient have significant side effect with medication. But because of the new neuroimaging technology improve, and the functional anatomy we understand much better nowadays, with also during the surgical period, we're able to monitor the testing the patient response with the electrophysiology, and the stereotechnical surgical procedure has been significantly improved over years. That makes it surgical treatment very attractive in Parkinson management now. So with what we say, hey, surgical is very attractive, it doesn't mean every patient with Parkinson's disease are the best responder or best candidate for surgery. That's why many times when we have those circumstances, we have to have a team to select the patient and evaluate patient, including team of a movement disorder neurologist, neurosurgeon who is operating, and neurophysiology monitor the response during surgery, and neuropsychologist who is evaluate patient cognition issue. And many now academic center may even including the speech, physical, or patient therapists as well, and as a team to evaluate patient, consider who might be a good candidate, and afterwards, and surgical post-surgical management as well. So what are those patients considered good surgical candidate and for surgical surgery in Parkinson? And those patients who have severe dyskinesia with best medical management, and those patients who has fluctuations with best medical management, meaning with significant wear off, and the levodopa still working, responding, except tremor, okay? In some patients, and even patients tremor not responding to levodopa, and their tremor are responsive, really responsive to surgical intervention. However, there are a few of the symptoms we need to pay very much attention, is that if the patient have significant dementia, if the patient has significant speech swallowing issue or autonomic dysfunction, like also static hypertension, those are patients may not be a candidate, good ideal candidate for surgery. Of course, ideal situation asymmetric means one side severe symptom, you don't need the both side surgery. One side surgery will be much better tolerate. However, it doesn't mean we don't operate both sides. There are many patients we operate both sides as well. So surgery and many of the old system is the ablative lesion to part of the brain, and it depends on which region was selected. Now, many of the center is very much using deep brain stimulator surgery, okay? And the location, actually selection is similar and just a technical different. One is just a lesion to the brain. One is insert the device into the brain. The outcome of the surgical treatment on Parkinson's disease and showing marked reduction of dyskinesia and significant decrease of time and increase on time with combination of medication management, and is very effective in terms of treating tremor, bradykinesia, rigidity. However, there are some area of the Parkinson's symptom, like posture instability, particular freezing. If those symptoms are not responding to medication, they're probably not going to respond to the surgery alone. Speech and swallowing usually are not able to improve by surgery. Some patients might have more cognition impairment after surgery. That's why before the surgery, we frequently do the memory testing, make sure patients are not demented, and they're going to consider a good outcome, a good candidate for surgery. Now, we frequently say, hey, Parkinson patient and takes a whole village to taking care of them. And that means it's not only just a neurologist. And neurologist is one of them, particular movement disorder neurologist. Yes, we have a surgeon for the surgical, but there's a lot of other areas might not actually just need medication. There are lots of non-pharmacological property and can be very helpful in Parkinson management. I mean, you guys involved in the Parkinson support group. What the support group do, and it's a patient caregiver education, basically. That's one of them. You're doing exercise together, and you are sharing the information and support each other. So that's very, very important. Physical therapy, occupational therapy, speech therapy, and exercise, and the social interaction, and diet and nutrition, all are important aspects in as a whole and holistic of the Parkinson management was. Okay, physical therapy and actually can help to maintain increased activity level, and it definitely reduces the rigidity and bradykinesia, and can facilitate the movement and flexibility and the gait, particularly some of the freezing gait issue, which may not responding to medication and surgical. And of course, and the goal is to maximize the gross motor coordination and balance, and maximize the independence, safety, and function. And having said the physical therapy part, and we always emphasize exercise. And there are more and more studies suggest that exercise not only improve the motor symptom wise, there are many of the non-motor symptoms and the depression and the fatigue and insomnia, constipation, and they're all actually improving with regular exercise. And exercise in many studies has shown that actually, and in long run, if you do regular exercise, can actually slow down the progression in Parkinson's disease. And many of those studies has been looking into that actually. And there's a plenty study, plenty of the exercise patients can do. Basically, it's based on patients' the age and physical ability and the level of the Parkinson's disease, and you can choose the one most suitable for individual, the patient self, to do the exercise. Okay, and occupational therapy. I don't think that I need to emphasize too much. I mean, we got you get OT's expertise, expert here too. So yes, OT also is an important part of the therapy in Parkinson's disease, and try to maximize the independence, safety, function level as well, and improve the endurance, reduce the energy expenditure. So basically, make a patient more function independently in self and safe as well, and some of the fine motor skill improvement as well. And again, there's a number of the occupational therapy programs, including the in-place and the home therapy program. Okay, and there's some number of the equipments OT frequently use and to help, and adaptive some equipment and environmental modification for Parkinson patient as well. Okay. Speech therapy, and actually, I would say frequently we probably underutilize the speech therapy. So speech therapy and actually should be used as early as possible. And it's not only the speech volume, they can actually evaluate enhanced swallowing. They can have the cognitive training as well. Okay. So, and Big and Loud probably is a very, if anybody has working with a Parkinson group, Big and Loud is one of the very useful speech and therapy exercise program has been utilized and beneficial for many of my Parkinson patients. Unfortunately, insurance is not covered for long duration of the therapy. I wish they can do that, right? Now, of course, there are lots of other modifications can be helpful for patients who is having swallowing difficulty, like do not rush in eating soft food or adjust the food, a smaller bite and chewing well before swallowing. Okay, empty every bite before they take the next one. So yes, even with all that, and some patients might be high risk, and family member might need to learn how to use in Hamnet maneuver as well for rescue. Okay, nutrition, and yes, it will be. It is important part of the management in Parkinson as well, and so. Sometimes this is where a patient may have difficulty prepare the food because of the disability, tremor or slowness. And there are times maybe because of feeding issue, like the swallowing issue. There are times maybe trouble chewing it. And there are times that maybe concern medication and the medication food, for example, protein and the lipitor intake. There are times the patient might have some the high thiamine diet and MMO inhibitor medication intake, or if the patient's medication have nausea, vomiting, or patient have significant constipation, what kind of a diet they can modify there. And the bottom line is that yes, patient need actually essential need for the body and energy-wise and protein-wise and fiber-wise. However, you also need to consider what kind of medication intake, what potential interaction with food as well. Okay. And so yes, patient need a balanced diet, sufficient calorie, but adequate fiber, fluid, and also concerned with sometimes protein and lipido interaction and as well. Vitamin, calcium, this is not like interacting with the medication mostly, but just essential probably patient needed for elderly population we see frequently. So education, support, and counseling is also very important. Actually, I'm proud, and many of my patient and family caregivers in this community, they're doing a great job and helping the patient and with Parkinson's disease. Okay, I think that's all I have. Thank you.
Thank you, Dr. Huang. You did a great job. I learned a lot.
Thank you.
Thank you.
I have a couple questions.
Yes, go ahead.
All right. So one of the questions that I thought of listening to your talk and that I've heard other people ask, is there ever a time when you would recommend, say someone's early in their diagnosis of Parkinson's disease, to kind of hold off on taking the carbidopa, levodopa, or is there really no reason for that, even if, say, they're rather young and they could go ahead and benefit from the quality of life that medication will give?
Well, there are times, I mean, it's just many times it may be just a certain individual personality, and they just reluctant to taking medication. I mean, they are frequent, have those people, and yeah, although not common, I do see that over the years. Probably, let's say how many patients I have, and this is the slides you're talking about. And over the years, I have probably maybe a handful of patients who just doesn't matter how bad they are, they just don't want any medication. I remember a couple of them. One of them say, I can do exercise, that's good enough. And other one, somehow they took the idea of say glutathione. And this is active patient travel all the way from Sarasota, come to see me. And he he swear the glutathione is the cure for Parkinson's disease. He just don't want to take anything else. I have a handful of those patients there for whatever reason, for other reason, they just don't want to take it. Yes, those patients, and number one, this is why we have a support group as a group and patient caregiver, and when they see you frequently, it's not like one time you can convert those people there, and it might take a long time to re-educate it, change their mind. That's part of it, but over time they see the progression of the disease. And as I say, that Parkinson even progress. It's not like next week when they're coming back, hey, you see your symptom worse. They don't change that quick. I remember one patient, he probably refused taking any medication for 5 years until one time he fell and admitted to the hospital and had concussion. And it's not only concussion, I think his head has had some bleeding, fortunately small bleeding. Mm-hmm. And that took him 5 years to that far. And he realized, okay, and hey, I know I have Parkinson. And yes, just refuse taking medication. I'm not going anywhere. And it's not only I have Parkinson, now I've seen the progression of the symptom. If I'm falling this one time, I'm falling another time, could be much worse. So finally, he realized he needed to start treatment. That taken that far until he fall and had the traumatic brain injury, he started taking the medication. So there are cases like that, unfortunately. I mean, hey, you can't force anybody to take it. They just say, since we're talking early on and the vaccine works for COVID, but we can't unfortunately force anybody taking that. There's some patients going to take a while to realize they might be wrong, or they might be not in the correct side.
That makes sense. Thank you for that. That's good. No, and I do want to say I appreciate you including the exercise and the diet. It seems like that's getting a lot of attention these days. And I don't have Parkinson's, but I try to go and exercise a lot now. And whenever I'm not feeling like it, I just remember that I should be grateful I'm able to do it, and that the benefits that it's having today, I don't even know what those will be tomorrow, but they're there.
Hey, I have to applaud all my patients and the families doing that for many years, actually. It's not easy. I mean, I try to do it myself. I'm not able to do the exercise every day myself. I mean, to be honest with you, it's not just simply, hey, do it. That would be nice if it just say as easy as I say, do it. It needs a lot of encouragement, lots of discipline. And many times it was just yourself, but probably you're not going to do it. And with the group, it makes it a whole lot easier. And I have been saying that last year is not easy, unfortunately, because of the COVID and lockdown, and not only for us. And I think it's much worse for the Parkinson patient. And their group is not able to get together, and they're not able to do much of the exercise together. I know. Last year is tough.
Yeah, agreed. Hopefully they're all starting to be able to get back together.
And things are better though. Yeah, definitely better. Yeah.
I totally.
Erica, did you have any questions? Anything pop up?
I just want to say thank you, Dr. Huang, for acknowledging occupational therapy.
Yeah. Good.
Yes. And does anyone else have any questions, or I can unmute people so you can ask yourselves if you would like to talk. I've given you all the ability to talk and ask questions.
Oh, I see Stan here, Marshall here.
Yep.
Hey, Stan.
Hello.
Hey, Stan. I don't know.
Their mic was mute. Yeah.
Let me see. I I don't have the ability to unmute anyone.
Yeah,
If
ask them.
people do want to ask a question and you can't come off mute, you could put it in the chat box and we can see it there.
They can
Sure.
as well.
Yeah.
So I found it interesting, Dr. Huang, that you said 200 people in the Jacksonville area will be diagnosed with Parkinson's, 200 new people each year.
Well, it was based on one. Doesn't mean it
Yeah.
has to be that. Just based on that kind of an incidence there. I mean, yeah. I mean, you might if it's really based on population wise, we have a million population in the area. Great. I'm not talking about just the Great Jacksonville area, including probably Fernandina and Jacksonville, right, and Orange Park and
right,
maybe St. Johns County as well, all together, this area. Yeah, I
you
mean,
know, Jacksonville is the biggest city.
Territory-wise, yeah. If you add all together, yeah. I mean, potentially, it was 20 new patients per thousand for 100,000 population. So this territory, you can have a 200 Parkinson patients a year, yeah.
So
that's
the numbers are, well, it's good that we have the next generation like Erica staying interested and being creative and starting new things for the community.
Think about it. I mean, the Parkinson disease is not like hey, you're gonna just see them one time, treat them one time, then they don't need anybody anymore. This is a condition. Number one, yes, we've seen so many new patients already. But number two is that with the new therapy, we've seen that actually patients live with Parkinson's disease much longer, and the life expectancy is much longer too. So we gonna accumulate more Parkinson patients over time too. So definitely there's more need to see all the professional manage Parkinson's disease to help the Parkinson patients. Not only just the movement disorder neurologists and many of your therapists, physical, speech, patient. Yep.
So Dr. Huang, I do have a question.
Yeah.
How often is it that you may treat a patient that has been like misdiagnosed and they may?
Well, this is where kind of interesting. Well, misdiagnosed can be both ways. One is that, hey, patient diagnosed with Parkinson, but it turned out it was a different thing. Or patient was diagnosed with essential tremor, essentially, I mean, after revisit is the Parkinson disease. I don't think that just simply just say how often, but depends on the circumstance there too. And yes, if in general speaking, if it's a movement disorder, neurologist, the chances of misdiagnosis probably is very low. Okay, because hey, and number one, they're trained in this area, they've seen those patients frequently, and they manage those conditions on a regular basis. On the other hand, neurologists, general neurologists, they might see share of the misdiagnosis, but general practitioner, like family doctor, yes, I seen there are much higher incidence of misdiagnosis. For example, tremor patient diagnosed with Parkinson. Yes, Parkinson patient shake doesn't mean everybody shake is Parkinson disease. And there are times, yes, there are times that patient actually, if it's not tremor predominant, Parkinson patient doesn't mean everybody started with just shaking. I have patients started akinetic type. It's a slowness, stiffness. Patient has been slow, stiff for years and not been diagnosed until they refer to my clinic as evaluation for balance issue. And when I examined the patient was actually Parkinson's disease. It's an akinetic type. So if it's a primary doctor, particularly, they're not familiar with many neurological conditions that can be easily misdiagnosed.
Thank you for sharing that. Well, I don't think anyone else has any questions. I would like to thank you so much, Dr. Huang, for coming and speaking to the support group. And I hope that maybe in the future we can do something live in person.
All right, good. Thank you. And thank you all and have a nice evening.
Thank you, Dr. Huang. Thank you, Erica.
Bye-bye.
Yeah.
Bye.
Bye, everybody.
Bye,
Oh,
everyone.
wait, not bye just yet, you guys. So I always do an affirmation of the day, and the affirmation of the day is I am growing and I am going at my own pace. So things seem like they're slow or not working how you wanted to work, but just know that you can do anything at your own pace and that you're going to get there and you're going to achieve everything that you want to achieve. And upcoming speakers, we have up next, we have Erin, and she is from UC Davis Health, and she's a nutritionist, and she'll be speaking to us July 21st at 5:30 p.m. And then Elaine, the lovely Elaine, she's on right now, and she will be speaking on advancements in deep brain stimulation on August 18th at 5:30 p.m. And if you have any questions for her prior to about deep brain stimulation, or even Erin, you're more than welcome to email me or contact me. And I just want to say thank you for coming.
Bye-bye.
Bye.
Bye, everyone. Thank you.
Thank you.